And we've got our final group of presenters here, and they probably have a very intriguing title for you all. So be frisky, not risky. And with no further ado, I will kick it off to the group.
I will just say that we gave people till 10:20, so if they're wondering in, that's totally fine.
Sorry,
but
sorry.
I'm going to hold this in front of my face so you can see it. But everyone, if you wanted to log into the poll EV that's in the chat, if you want to do it on your browser on your phone, you can do that. If you do it on your computer, you will lose the slides while we're presenting. So if you want to just open a browser on your phone and go to pollev.com/NateUNC, then you can participate on your phone while you're watching. So that might be the best technical setup. I think we're all back. We're early people, so I think we're good.
Okay. Rachel, do you think I need to repeat my intro, or do you think we're good to go?
I don't know if it's a healthcare leadership or management mantra, but something like just go with it comes to mind. So.
Yeah. All right. So anyway, take it away. Be frisky, not risky group.
Okay, well, we will just go with the mantra and just go with it. Well, thank you everybody for joining us this morning and allowing us to present our HCLM project. The title of our project is Be Frisky, Not Risky, and is a project focused on reducing teenage pregnancy in North Carolina, as well as increasing sexual health knowledge and access to health resources, sexual health resources for teens in North Carolina. Before we start, we are going to have some polling questions interactive. I know we've kind of emphasized that, but we want to make sure everybody has a chance to participate. So please make sure you either have that on your screen or on your mobile, your smartphone. Our team includes, sorry.
We're glitching. I'm sorry, Frank.
That's okay. No worries.
Let's try this again.
Next slide. No, back up.
Apparently your slides didn't want to start until 10:20 either. So give me just a second and we'll get this figured out. Let's give this another go. Hopefully it doesn't have a mind of its own.
Next slide. Next slide. There you go. That one. Ooh.
Now bear with me just a second. I'm going to see what's going on. For some reason, it is auto flipping itself. So hang on just a moment. If you want to converse, give me just a second. We'll get it figured out.
This is where we need the music, Dr. Keever.
Yeah, I've got the Jeopardy music in my head right now, but you guys don't want me to sing it, so.
I will call attention to the chat. I know not everybody looks at that, but Pam put a great comment about, as we think about this, we're lengthening, strengthening the pipeline, we're broadening the pipeline. What about a database? And I love that, spoken like a true fundraiser, that Pam realizes, the idea of being able to study and measure that is really contingent on collecting or having a structure to collect the data. So that's super true in anything we want to measure.
How's it going there, Aubrey?
She's
I will.
She's excited
let you know in just a second.
In the spirit of Halloween.
It is. It did not do it this morning when I received it, so I'm not sure what's happening. Bear with me just a minute. I want to make sure it goes smoothly for everyone.
The PowerPoint's being frisky this morning.
I do think, I think about how much technology has been forced upon us. I was always very intentional in my technology choices before. And I really, I mean, I think it's important for us to acknowledge the, the sort of the built-in frustration. I think, EMR conversations are ongoing and we still haven't solved for some of those frustrations, but adding Zoom to your social life and, creating everything you do in PowerPoint form. I think it is kind of interesting. I don't know if this will be the death of these technologies because people will be so tired of them, or if it will actually just become part of, it'll be just like texting, right? Well, I sent you some PowerPoint about that. It's an interesting time we live in.
I blame this on Frank.
You blame this on me? Okay, all right.
I strongly suspect that's not the case. How many people have been to a live medical conference this year? What did you think? Were you terrified? Was it great? Did they do a good job?
Oh, they did an excellent job. Yeah.
What made you feel safe in an in-person meeting?
Just the attitude everybody had. I mean, everybody was conscious about it. Everybody wore masks. So there was no argument about it. And surprisingly, I would say 90% of the people at the hotel, staying at the hotel, were wearing masks as well, and they weren't even part of the conference. So I felt completely safe.
Was that the MGMA meeting? Or was that a different one that you were at?
I've been to two. One was the MGMA, and the other was the endocrinology meeting that we had.
Yeah.
In
MGMA did a really good.
Aubrey,
Yeah.
I think I have the answer for you.
Okay, I will take it.
If you go to the slideshow page,
Mhm.
and it's, if you check those boxes, play narrations, use timings, and show media controls.
And what tab would that be under?
Under the tab for slideshow.
Okay.
Apparently, when you update it, it automatically checks those. I just
Dr. Garrett, this is day 2 of you teaching me a lot about these PowerPoints.
I'm not teaching you. This is my
Thank you.
husband's teaching. I called him for support. So
Hang on just a second. Let me make sure it's gonna.
Healthcare is a team sport.
Wow, we're gonna have to keep him around. All right, everyone. I am so sorry about that. Let's go ahead and retry this, and then we should be good to go. Thank you all.
Okay. Okay, thank you, Aubrey. Just to recap, our project is called Be Frisky, Not Risky, and we want to make sure everybody has the polls questions up. You can see how technology works tremendously well all the time. So next slide, please. Our team consists of Dr. Latanya Beatty, who is a family physician in the Wilmington area, Dr. Therese Garrett, who's a psychiatrist in the Chapel Hill area, and then I'm Frank Snyder with the Medical Society. And what we're going to do is we're going to start off with Dr. Beatty providing some background on our subject matter and also how we arrived at this topic for our project. So, Dr. Beatty.
Good morning. Next slide, please. When discussing our project, our group wanted to pick a project that included a focus on a healthy NC 2030 goal that also tied to social determinants of health. We basically wanted to identify a need or service that is not routinely utilized. As a family physician at a FQHC, we offer prenatal services as well as preconception services. Most of our women, including young teens, often present in the second trimester. Some of them have baseline risk factors such as obesity, substance use, and STDs for an unknown period of time. Our young teens often present late due to lack of transportation, either feeling embarrassed or ashamed, or they didn't know that they were pregnant. When presenting late in the second trimester, there is a missed window to prevent many adverse maternal and fetal outcomes, as the most critical period of fetal development occurs between weeks 3 through 8 following conception. This may also limit their ability to either decide to terminate or keep the pregnancy. So as As a group, we decided to focus on increasing awareness of adolescent preconception health. Next slide, please. This is an interesting slide. Teen childbearing costs US taxpayers $9.4 billion annually. Let that sink in. Teen pregnancies can have immediate and long-term negative effects for teen parents and their children, as well as create substantial social and economic costs to our society. Next slide, please. Here's our first poll question for the group using the website provided in the chat box within Zoom. And the question is, which county in our state do you think has the highest number of teen pregnancy rates currently? Click on the link or copy and paste the link in your phone or computer device, which I'm thinking most of us is already there. It should only take about 30 seconds to hover your cursor to pick which county that you think is the highest in terms of teen pregnancies. And I see some responses coming through. It's very close so far as in terms of the region. We'll allow a few more seconds and then we'll close out and head back to our presentation. Okay, so I think we're ready to close out the poll. And thank you. This is our area of focus within the state concerning some of the counties with the highest numbers. On the next slide, we will outline the individual counties that we choose specifically. Next slide, please. Here are the 7 counties out of the top 10, which is ironically geographically close to each other in the Pacific region. They're also likely to have some similarities in terms of some of the barriers to access. Next slide, please. The counties listed on this slide are clearly the highest in numbers, averaging up to the 30s and 40s in terms of pregnancy rate and birth rate. Also higher than the state average, which is 18.7. It looks like a majority of the answers were pretty close in terms of the region. Next slide, please. Next, we're going to talk about our intervention. This is our intervention, which includes the development of an app. Why an app? Social media plays a big role, as we most know, for millennials today. Studies show that 2/3 of teens have their own mobile device with internet capabilities. Other reasons include limited access for local health departments to connect with students since the pandemic. Most of the health departments that I reach out to mention use of Facebook, Twitter, posters, billboards, but limited school exposure to increase awareness. As we know, the majority of schools had transitioned to remote learning early in the pandemic. Community outreach events were also on hold. Lastly, in the 2020 County Health Needs Assessment, in the counties that we choose, the most common rated source for health information was one's doctor or other healthcare provider, with the second highest rank as internet search. As we outline our intervention, I want you to think about the mobile health apps you have downloaded previously. Components of our app will include, but not limited to, age-appropriate content regarding sexual and reproductive health, as well as preconception health. Lastly, opportunities to increase access to various community resources concerning sexual and reproductive health. Next slide, please. Partnerships in our targeted counties include connecting with local resources listed here to assist with coordination of care, content development, and possible funding opportunities, ideally with the goal of looking at state and federal funding that will be mentioned later. And now we'll pass the presentation on to Therese.
Next slide. So our focus for this intervention will be youth ages 12 through 20 in the counties listed in southeastern North Carolina. We chose to focus on 7 of the top 10 because the other 3 were in disparate regions of North Carolina. And earlier, Dr. Beatty asked you to keep in mind mobile health apps or digital health interventions that you may have downloaded or used. And in the next interactive question, we're going to ask you to choose one of the responses as to what led you to stop or decrease use of the app. Next slide. So go again to Poll Everywhere, and you'll see a list of options of reasons that you may have stopped or decreased your use of a mobile health app. One challenge is that many apps, even when they're downloaded frequently, they don't receive much use. We'll probably give folks about 10 more seconds just to click on if they haven't. You'll see here some of the most common reasons, and actually the biggest and most important here being that they're boring or not interesting. And that actually does seem to be one of the driving factors, especially for a lot of health-related apps, is that they're not particularly interesting. They're designed to be informative, but they're not much fun. So we'll talk a bit about that as we move forward. Next slide. So some of the things that are important in thinking about the functionality and accessibility, first and foremost, because poverty is a risk factor for teen pregnancy and the most frequently cited barriers to healthcare access, limiting folks like some of the patients that Dr. Beatty talked about from getting connected to healthcare are cost and lack of insurance. So we want to ensure that the app and the website is able to remain totally and completely free. Also, because there's limited broadband access in rural communities, especially in some of the counties that we're targeting. For many, primary points of access may be schools, libraries, or other public Wi-Fi access spots. And also, while there are a lot of students who do have smartphones, there are many that may not have smartphones, and their primary access may be through school-owned devices, which thankfully a lot more students do have. If there is any good thing that's kind of come out of the pandemic, it has been that there's a lot more educational tech available. And so for those students, they may be accessing it only from school-owned computers. And so it includes an app as well as a website. Also, again, because of the intermittent internet connectivity, we want to ensure that there are some offline capabilities. So some of the offline capabilities would include birth control reminders, menstrual cycle tracking, downloadable health content, but there'll be other aspects that do require online capabilities, such as geolocation using GPS to find nearby clinics, or push notifications when a mobile pop-up vaccination or health clinic, such as the vaccination station, is within a certain mile radius. Next slide. To address some concerns about social privacy, as that was one of the things that was indicated as a reason that individuals sort of stopped using apps, one of the important things that we would want to make sure is that there were ways that folks were able to keep this private, especially if they're shared devices that they may be showing to their friends, or a device that's a family-owned device. So there would be an option for reminders or messages from the chatbot to be accessed only through a PIN-protected area of the app if folks didn't want to receive push notifications or texts. Also, details on minor consent would be prominently noted, including some of the limits of minor consent in North Carolina, particularly related to abortion, while also encouraging teens to talk to parents or trusted adults in their lives when possible. Data collected by the app for evaluation purposes is going to be aggregated and de-identified, and there will be an option to opt out of data collection. And then teens, as they're using the app or after a certain amount of time of using the app, could also select to receive some survey questions from the chatbot intermittently, which would be used for app revision and modification of content, as well as future outcomes measurements. Next slide. As Dr. Beatty discussed, much of the content is going to be sexual and reproductive health information, but with a plan to reuse rather than reinvent content from expert health sources. There's no reason for us to sort of restart and rewrite things when there's a lot already out there. More of it is about trying to get folks connected to some of the good information that's there. We'll also include targeted health information that's based on health status or behaviors, as well as personal health tracking. Also, as there are other factors that are influencing adolescent health, we want to include crisis management with suicide and prevention crisis hotline contacts, including those that are targeted to gender and sexual minority youth, as well as resources and supports for racial minoritized populations. Other content that's related to non-sexual health behaviors, but that impact adolescent health and maternal infant mortality would include resources related to smoking cessation and the quit line, brief substance use screening and treatment options, as well as supports for interpersonal violence. Next slide. Then lastly, and this is kind of one of the most exciting parts because most folks said that they were bored by mobile health apps and that's why they didn't use it. And that's very true, is that much of the focus on health has not been on the user experience and engagement. So key to meeting the needs of adolescents, and in all honesty, adults and everyone, is a focus on this user experience and engagement, especially because the vast majority of apps that are available, they're not targeted to young people. They may be sort of overall targeted, but are not focused on the population we're looking at. And there are many that are single function apps, such as birth control reminders, menstrual cycle or fertility tracking, or the ones that are fairly boring, which are health content with limited interactivity. Earlier, we've spoken a bit about some of the notifications and AI triggered messaging, which will be targeted to what a teen has been accessing in the app. But there will be other ways that some of that content will be delivered, sort of focusing on what individuals have chosen. Also, there'll be some personalization options, including an avatar, which can represent any one of a variety of racial and ethnic backgrounds, as well as gender inclusive backgrounds. And then to get to some of the how do we make it more exciting, adding games or game-like elements to learning has been a really prominent feature within the K-12 educational apps. And any of you who have children or interact with children have probably come across this in the past year and a half with the remote learning piece. But it's not utilized very often or well in digital health interventions. So our game elements will tie into some of the underlying health goals, including contraception adherence, healthy communication skills practice, healthy sexual behaviors, and preventive healthcare, with points to be earned and in-game rewards. And these elements will integrate some of the educational content into fun and strategic gameplay to combat misinformation. So next, I'm going to pass the presentation on to my colleague, Frank Snyder, who's going to provide additional information on the business aspects related to our intervention. Frank, you're up. Next slide. Go back one.
Sorry. That's going to lead us to our third poll question, and that is going to be, which component is most useful, or would you consider to be most useful to your patient base of this application? And we'll give you a few seconds to make a choice. It appears that we have hit a nerve with the boring and gamification aspects of the application. So that's good to hear. We'll give you a couple more seconds and then Dr. Garrett, if you'll close that out. Clearly the gamification was the important content, keeping people interested. Next slide, please. As far as the budget goes, we would be looking at startup expenses or startup costs. The app development would include the application design as well as the launch and maintenance of the application. This would be a contracted part-time position, and the design would be more or less viewed as a one-time cost, with most of it going towards the support, any tweaks that might need to take place with the application based on interaction with some of our resource websites or anything of that nature. The marketing, we would market to a variety of smartphone platforms such as Google Store or Google Play or App Store, Apple Store, and also use social media platforms for advertising such as Facebook, Twitter, and Instagram. The marketing for it would also be related to local schools, health departments, and also healthcare systems. There are a lot of healthcare systems, larger healthcare systems that would benefit from this type of an app. And we would also target them as far as marketing to the teenage population in those areas. Next slide. Some of the funding resources or sources that we would utilize would be U.S. Department of Health, obviously the North Carolina Department of Health and Human Resources. One of the other teams mentioned the CARES, NC CARES as a possible funding source for their project. We would also consider that, as well as some other Medicaid payers, anybody who would benefit from reduction of teenage pregnancies in the state. Next slide, please. The outcomes, we're looking at some short-term and long-term outcomes. The short-term outcomes, of course, would be to increase appointments for preconception education and access to preconception healthcare. We would be looking at the number of hits or the number of clicks that the application received, also the number of downloads, also the number of users utilizing the geolocation access for various health services in the rural communities. And we would also be looking at modifying behaviors, increasing contraceptive use, increasing sexual health knowledge, and also reducing high-risk sexual behaviors. The long term, we'd be looking at hopefully the app would help us decrease sexual transmitted infection rates, reduce the number of teen births, obviously, and also reduce the number of repeated teen births. That was a number that we came across that was high for North Carolina as well. And then for future plans, we would do a regional feasibility study in this focus area of the state that we're targeting. We would look to see how it did in that area, make any adjustments to the app that we needed, and then look at possibly expanding it on a statewide basis. The other thing that we talked about doing for our future expansion of the app that I thought was kind of cool was to look at some type of user-to-user mentorship program with a peer support. It's one thing to have this information available to you, but it's another to have an actual person who's experienced it or is going through it themselves to support you in that way. So the mentorship program, I think, is something that is important going forward. Next slide, please. We are anticipating several barriers in the rollout of this application. Connectivity, broadband in rural areas of North Carolina is terrible. Most of us know that, and that would need to be addressed. Web content filters for schools regarding the sexual material or sexual health material, that may be a possible barrier with schools' restriction on the internet access. Social norms. Sexual health is a touchy subject in a lot of communities, a lot of rural communities as well. So that would need to be addressed. And then community opposition to the comprehensive sexual health education. That's kind of falls on social norms, but sexual health sexual health education is not implemented or dispersed in the way that it needs to be in these areas. So next slide, please. And this is kind of a roadmap of the overall project in the rollout. Again, we would do a feasibility study based on the number of hits, the number of downloads, the interaction that we had for users on the app, and make any revisions at that point. Again, we need to target our advertising and education towards specific age groups in these rural areas, and then the evaluation, and that goes back to the feasibility study somewhat. But we would look at the number of hits, the number of downloads, the uses of the app, and hopefully this would allow us to go to other resources, other organizations around the state to say, this is an engaging app. These teens are looking at this app, and hopefully over time we would see a reduction in teen pregnancies overall. Next slide. That is the end of our presentation. Does anybody have any questions?
Frank, I've kind of the same question I was asking that earlier group. Like, what is this, or have you all considered the scale of penetration you would need to have an impact with this app?
Well, I think that's why we chose the region that we did, because those are 7 of the top 10 counties for teen birth rates in the state. So once we did that, once we saw what the engagement was, and it would take some time. This is not something that we're going to be able to measure in a 6-month or probably even a 2-year period. It would take some time to see the results of the interaction. I don't know if that answers your question or not.
One of the things that I can speak to about that is, one advantage actually of sort of rural counties that are lower population is that, at least with regards to connecting to some of the schools, which is one of the big places where we would be doing a lot of outreach, is that there aren't as many schools as if we were doing Wake County. I honestly have no idea how many high schools are there, but it's quite a few. But when looking at, some of these counties only have 1 high school, we would be looking at middle school and high schools. But it's I think in total, the middle and high schools was less than 20, which is a doable number to communicate and start developing relationships with, in contrast to much higher population counties. And I think the other piece where we feel really strongly about making an intervention in these counties is not only do they have the highest rates, but many of them also really lack comprehensive sex education. So in 2016, Onslow County actually voted to change some of their sexual education curriculum. And at this point, one of their board of education chairwoman very clearly states that they have a comprehensive health curriculum, but not a comprehensive sex education curriculum. It's family life education policy, but it's abstinence-based, family-centered, and age-appropriate, which abstinence is great, but it's also not realistic for everybody and is not going to sort of solve the problem. So I don't know if that answers your question.
Yeah, no, that's fantastic. And I agree that abstinence is a great message, but it's not spot on. I love that y'all are, I think back and I used Dr. McMahon's Kipple program project on long-acting reproductive contraception years ago as an example of making that local impact. And I think what you're talking about is something that where she made an impact in Harnett County, you're talking about trying to hit a whole region at once. And so I love the idea of just trying to think of like a timing and kind of scale piece, right? How long, as a part of the sales pitch. I'm also reminded that our external affairs team just met this week with grad students from Princeton University working on behalf of the Department of Health and Human Services, who's contracted with them to determine various projects that are working or should be working in the state of North Carolina to improve maternal and infant care. So this is probably a really good time to connect you all, not just with that Princeton grad group, but with DHHS, as they have educational money right now from the federal government. There may be startup funds there to get something like this off the ground.
Yeah. Well, then I think also sort of in speaking to how folks access this and how folks get connection to this, I think, because Facebook tracks everything you do, one of the things that has started popping up on my Facebook algorithm has been this link to NCDHHS has an STI testing locator. But what's fascinating about it is I've seen this ad pop up and I didn't click on it at the time, but I was like, oh, that must be because of all this work I'm looking up. But I can't find it. When I wanted to add a picture of it in this presentation, and when I searched on Google, I searched a bunch of different ways, and I consider myself to be an advanced Googler, and I still couldn't find it. So if you click on the ad in Facebook, it's great, you can find it, but that's seems to be the only way that you can locate it. So really being able to have some of these things link in. The other really important piece that I wanted to bring up is the focus in our project on reproductive justice, because a lot of focus on teen pregnancy prevention and all this has been the historical framing of teen pregnancy with young mothers as the cause of a variety of social problems, with sort of really the primary policy and only practice approach being pregnancy prevention. But part of this is also looking at reproductive life planning and ensuring that folks are able to, one, respect the right of individuals to choose to have children, to really decide the conditions under which they get pregnant and give birth, and then to be able to sort of parent their children with support, safety, and dignity through some of these mentoring and relationships that would be sort of next steps.
On one of the slides, it appeared that the higher rates of teen pregnancy was in the eastern areas of North Carolina. Did you, in your research, were you able to identify any particular reasons for that? Did you think it was poor access to birth control, or could it be other socioeconomic conditions or cultural conditions?
It was more like a combination of everything that you mentioned, with mostly it being limited access and limited awareness.
Right. I think, yeah, the access and awareness piece kind of interact together, as well as does the poverty. There was a study which had a really interesting heat map showing where they were looking within North Carolina about distance from a Title X facility and how that related to teen birth rates. And when they just looked at that, what's interesting is that the heat map, the area that was in black basically was this sort of crescent area that we selected as the counties that we're choosing. But I think overall, it was not found that that was a sole predictor of teen birth, but it interacted with poverty and lower education and other aspects of things. So the distance itself is not the independent factor. So it's, I think as all of us know, it's not as simple as just stick a health clinic on the appropriate corner and everybody gets better.
And Dr. Apollonaro has a question in the chat. What incentives are there for teens to use the app aside from gamifying it? That was not really something that we dove into too much on the incentive side. That would need some more development.
And a lot of that will depend on the money, right? Like, I think, the money piece is really going to determine what kinds of incentives and how much incentives. I mean, I think probably if we found with the chatbot for survey questions that we were using, if we weren't getting response there, and if we had the money, being able to incentivize some of the questions would be really important. But I think that that's somewhere where I don't want to set on the front end, this is exactly what the incentive is going to be, because if we don't have the money to back that up, then we're kind of stuck there. The hope for some of that would be to get more money by, once we have some of the data with who's clicked on what kinds of things and all of that, to be able to show some of that to the state or the local health departments or health systems that are responsible for communities, to be showing like, hey, here's what folks are checking out. Here's what folks need. Can you give us some more money so that we can try to develop some of these other things? Then I also see that Dr. Bhatia put in the comment section, as an aside, my kindergarten is using an avatar-based app and it is highly effective even at that young age. I would agree, and sometimes it's disturbingly effective in terms of, the negotiations around that. I mean, I think that is one of the barriers or risks that we didn't talk about, is with regards to addictiveness of games. And obviously we don't want to sort of set something up that then is addicting folks in that way. Like, there's an example of, there is an educational game that my first grader is playing, and every day, if you open it every day, you get more coins or something. And so he's always like, Mom, in the morning, can I please log in? And it's a little disturbing to me with that. But I think this gamification piece is really a big deal. And it's something that the World Health Organization is looking at with regards to COVID. There's an app that they just came out with 3 weeks ago that was developed in partnership with the World Health Organization called Antidote COVID-19. And it's a game where you've got your cells kind of try and different things that you have, try to kill off bad little viruses that are coming in. And in it, it's got various bits of educational material, like talking about what monocytes do, or talking about why certain, things don't work to fight. And since that health education content, only 18% of you thought that was important or useful for your patients, while 64% of you thought the gamification was, we need to get that health education content in there. It can't just be games for game's sake. So we can find ways to sort of put some of that stuff in there so folks are learning while they're having fun.
So are there any more questions for this last group of presenters? Sounding like not. And so Rachel and I've been communicating in the background and really appreciate everybody's amazing presentations and the engagement of the folks listening to the presentations, as well as evidenced by the great questions and the great conversation that came out after this. And I think the responses that each of the teams gave to, I think, pretty challenging and provoking questions is evidence of the effort that went in to researching and really creating the foundation for the projects that they've presented. So what we'd like to do, if possible, Aubrey, is go ahead and pull up the graduation presentation, and if folks would give us a little bit of permission to skip the 5-minute break, we'd really like to allow everybody to have everything wrap up timely as much as possible today. So first off, I know Rachel and I would both like to extend our congratulations to the graduates of our Healthcare Leadership and Management program here in 2021. This has not been a year without challenges, obviously. As Rachel mentioned in her introduction, we've had to deal with COVID and the stresses of Medicaid transformation, some of us on all sides of that Medicaid transformation, all at the same time, while really conducting a program that was originally designed to be heavily in-person and interactive with a huge component of networking, and do that all virtually. And this group has really risen to the challenge. And I personally can't be more excited about the work that everybody has done this year. So next slide. So the pessimist complains about the wind, the optimist expects it to change, and the leader adjusts the sails. It's a great quote and great evidence aligned with everything that we've been working with this group this year. So again, congratulations. So next slide. So our first graduate today is Latanya Beatty. And Latanya is an OBGYN specialist with in Asheville, North Carolina. Actually, I think it's Wilmington. Sorry, Latanya, if we got that wrong on the slide. And Latanya's favorite quote is, "A leader sees greatness in other people. He nor she can be much of a leader if all she sees is herself." And that's from Maya Angelou. Congratulations, Latanya, for your amazing participation and success in the program. Next slide. Our next graduate is Mina Badia. Mina is an anesthesiologist in Chapel Hill, North Carolina. And Mina's favorite historic medical hero and mentor is Denton Cooley and her father, which I think is just lovely. Congratulations, Mina, on your graduation from Healthcare Leadership and Management. Next slide. Pete Bird. Pete is with us with Carolina Complete Health Network, a healthcare administrator in Raleigh and Durham, North Carolina. And Pete's favorite leadership book is Endurance, Shackleton's Incredible Voyage. And I loved Pete's comment on this. If he can lead his team home from the South Pole, I can certainly lead my team through our part of Medicaid transformation. So congratulations, Pete, on your graduation from Healthcare Leadership and Management. Our next graduate is Jennifer Dabbs. Jennifer is a healthcare administrator with Carolina Complete Health Network, also in Raleigh and Durham, North Carolina. And Jennifer's favorite leadership quote is, "Leadership and learning are indispensable to each other." John F. Kennedy. Congratulations, Jennifer, on your graduation from Healthcare Leadership and Management. And next graduate is Dr. Therese Garrett. Therese actually works with me at WellCare of North Carolina and Centene. She's a child and adolescent psychiatrist and a medical director with us in Raleigh and Chapel Hill, North Carolina. Teresa's favorite leadership book is Through the Labyrinth, The Truth About How Women Become Leaders, Alice H. Eagley and Linda L. Carty. Congratulations, Teresa, on your great work in the program and your graduation today. And Rachel will be introducing the rest of the grads.
Thank you, Jeannie. Dr. Eleanor Green joins us from High Point, North Carolina, where she's done work with the VA. I am in awe of this physician. I believe I can share with this group that she did her first connection with us from the bedside of a family member in the hospital. Dr. Green shares with us her favorite leadership quote from someone we lost this week, Colin Powell. The quote is, "There is no secret to success. It is the result of hard work, preparation, and learning from failures." Congratulations, Dr. Green. Our next graduate is Quincy Jones. PA Jones works at TROSA and is a faculty member at the Duke PA program. There's almost nothing that PA Jones can't do. And I am honored today to say that she joins the rank of one other unique Kipple alumni in that she is a triple Kipple. She has participated in 3 Kanoff Institute for Physician Leadership programs, and on her graduation today from Healthcare Leadership and Management will become the second ever person to achieve that. I also want to share with you what I think is important about PA Jones. She is a voice. Her favorite leadership quote is, "True leadership often happens with the smallest acts in the most unexpected places by the most unlikely individuals." And she shares that she has a platonic crush on Dr. Harvey Estes. Congratulations, Quincy Jones. Dr. John Rusher is a pediatrician who will become the next president of the North Carolina Medical Board. I had the pleasure of training with John in my medical career, where he came from law. He shares with us that he believes that leadership is an action, not a position. His favorite medical mentor is Wally Brown, retired pediatrician and senior partner at Raleigh Pediatrics, where he practices. His leadership aspiration is to build a cohesive North Carolina Medical Board during his presidency year. Congratulations, Dr. Rusher. And our last graduate is Frank Snyder. Frank makes you better every day. If you've had the chance to spend time with him at the Medical Society or through Healthcare Leadership and Management, you feel that. He shares that his leadership quote that he values is that being a leader doesn't require a title. Having a title doesn't make you one. I love that his favorite medical mentor was his hometown pediatrician, Dr. Leila Denmark in Atlanta. Congratulations, Frank Snyder. I am so privileged to work with folks who have this kind of extra dedication, who are willing to spend their time to make themselves, their communities, their patients, and their organizations better, that give to the Medical Society in all those different ways. I am looking forward to meeting with each of you sometime in the next year in person as a group to celebrate your graduation. But in the short term, know that we are inspired today. We take apart the work that you've done and use it as a scaffolding for the next week, the next month, and the next year through this pandemic. I'm going to let everyone take a few moments to speak with each other, because this will be our open Zoom social time. And if anyone would like to talk with their classmates or share a favorite healthcare leadership and management memory, again, remember, those are all virtual memories. This entire group has bonded through this platform, which is a pretty amazing feat in and of itself. I want to express my appreciation to Tina and to Aubrey and to all the staff of the Medical Society that support this program. To Jeannie, as a co-chair, could not ask for a better teammate in this work. And I look forward to just having a few moments to sit and talk with you.
Thanks, Rachel. And my only other closing comment is that I truly hope that this is not the beginning and the end of folks' participation with us at the Medical Society. Rachel and I and Tina and others had the opportunity to talk with the Medical Society Board last weekend about the KIPL programs and the impact that those programs have had on the leadership roles across the Medical Society, both the Society, the Foundation, all of the Society's committees. And, you know, Rachel and I have been involved with Medical Society on a whole lot of levels for many, many years now. I found it to be very fulfilling and impactful, and love the fact that a lot of our former KIPL alumni are participating actively with the Medical Society going forward. So really hope that this program is really just a part of your journey with us at the Medical Society, and really appreciate everybody's engagement and participation this year. So thank you.
I want to thank everyone who joined us. I see Dr. Jordan on the call. He's taking on his year as president of the foundation, which is very exciting for all of us. Also, just like I said, faculty and people who have previously gone through the program, feel free to come off mute and share your thoughts about what we should do differently, anything that you would like to add in terms of your experience or thoughts. And also the challenge that I'm going to put down here, which is these projects have second phases. They can be executed. And if you're interested in participating in that work with a team, please connect with them. I really think that we've seen over the years, these are the beginnings of change in healthcare. And while we form these teams, there are people in our resource circles that can add, as we have talked about with Old North State or other partners that can join us in these projects. So this is the beginning of those conversations. So if you're particularly excited about a project and you want to reach out to someone in healthcare leadership and management who's graduating today, now's your time. Feel free to do that as well.
We've never seen this group be quiet. I'm taking us back to yesterday in our attempt to solve the problems of healthcare access and physician burnout. Some of the favorite parts that I've had with working with this group over the past year have actually been some of those more informal moments when we've really had a chance to chew on and digest and try to problem solve some of the big challenges that we have in healthcare today. And I really look forward to folks continuing to participate in that dialogue and see what we can do to fix things.
This is Lyndon Jordan. I just wanted to add my congratulations just to a wonderful accomplishment. Kudos to all the graduates, the program leaders putting it on, and the staff. Just all so well done. Congratulations.
Yeah, this is Chip. First of all, thank you for allowing me to be off camera today. I've been on camera for like the last 3 days straight, literally like morning to evening. So it's been a really wonderful thing just to be able to sit in my living room and watch this without having to be on camera. But I just want to say, we talk all the time about the vision of the Medical Society and the Medical Society Foundation being to improve the health and well-being of everyone in North Carolina. And that is the truth. That is what we're all shooting towards. But an essential piece of the Medical Society being able to have a chance at doing that is creating smaller pockets of community amongst physicians, PAs, other health providers, professional staff, because that's where the real work gets done. And KIPL, there's no better example of that within the Medical Society than KIPL. The way that you bring people from very different places, very different walks of life, come together and solve really challenging issues and come up with creative solutions, not just kind of more of the same. I'm just regularly impressed by these programs and by the people that participate. And yes, we want you to stay engaged. And yes, we want to continue these programs and see them to fruition and not just be an idea factory, but be somewhere that actually turns these things into action. So continue to lean on us, and we will continue to lean on you, and together we'll really make an impact. So thank you so much.
And I will just say thank you to Dr. Keever, Dr. Comaviz, especially Tina and Aubrey. Trying to keep a group like this engaged face-to-face is difficult enough, but to do it in a virtual setting I think was a bigger challenge than perhaps anybody thought it might be. But we've done it, and you've made it interesting. You've made it educational, and we have learned a lot. So thank you.
Well, don't forget, we're all we have an appointment for next year, right? Somewhere, did we say Amstead yesterday? So I'm personally excited about thinking about us all getting together, and I think Dr. Comaviz and Dr. Keever and Aubrey agree with me when we are talking about bringing all of the alumni together, because just as you've heard from people here today, this group is so phenomenal in terms of taking, and I love what Dr. Keever always says, take a wacky idea and bring it, and let's look at things. Let's look at things differently, right? And this is the group that consistently does that. And I have to say, it is really a favorite moment of mine hearing your projects come to life, because I hear how you come together and brought in all of your experience and your thoughts and your insights about what's going on out there. Together with, together as a group, and then adding that up, and then with some new insights, and then coming to fruition of projects like the ones that we heard this morning. So thank you. And we're gonna send out a date, I think, sooner rather than later. So we do make sure to get it on your calendars, because you're busy people. So we've learned that getting things on your calendars as soon as we can is really good. So thank you so much for allowing us to be part of this journey, this moment. But again, it doesn't end here, but it continues. So just thank you so much.
Thank you.
All right, no better way to, go ahead.
I was gonna say, on a less fun note, I have a couple of things that I want to remind everybody of. You won't stop getting emails from me, so don't get too excited, everyone. The CME will be turned in tomorrow, so you should be receiving an email from Southern Regional AHEC, and they will have it. It takes them a couple of weeks. I know they're super busy right now, so hang tight. If your mailing address is different than what it was on your participation form or your application, just shoot me your updated address. We have something we want to send to you. I might just pop in to annoy you all from time to time, just for fun, just because we miss you. But other than that, everything should be good to go. You'll have access to the portal for probably another few weeks. So if there's anything on there you all want to grab, go ahead and go in there and grab it. And if you all have any questions about anything on the back end, anything with CME or attendance or anything like that, just shoot me a message and let me know. That wasn't as fun as everyone else's, but thank you for your time.
Thank you so much, everybody. I think, Rachel, it feels like we're ready to wrap up.
Have a great week, everybody. This is a beautiful way to start a week. I really appreciate the time here. And again, when you give time, we know you're giving up something else. We hope in return that you feel that connectedness, and that, like I said, this is not the end, but the beginning of some great relationships, some great problem solving, and some really, really important work. Thank you so much. Everybody have a great day.
Thank you.
Thank you so
Bye-bye.
much.
Thank you. Bye.